Tiger Woods' car crash. 5 very important considerations for his recovery after his accident.
Ladies and gentlemen, can I please have your attention?
Hey interns, I am Dr. Chris Raynor and I am not your everyday ortho. I make sports injuries, orthopedic surgery, and medical topics easy to understand for you.
Okay.
Today for Orthopedic Rounds, I'm going to be talking about a recent injury to one of the greatest golfers of all time, Tiger Woods. While other content creators have talked about the accident and the injuries in general, I'm going to be talking about several critical factors that will influence his recovery and determine when and if he will be able to return to professional golf in the future. If this topic isn't for you, please check out one of my other videos where I talk about sports injuries right here. I would appreciate if you support the channel and show the algorithm that you dig what I do. I am here to help you, so if there is a topic that you want me to cover, then let me know in the comments. I will cover the topics with the most engagement in the comment section. Otherwise, let's get to the topic at hand. As you likely already know, professional golfer Tiger Woods was involved in a single vehicle rollover collision in Los Angeles earlier this week on February 23, 2021. He was the sole occupant of a vehicle in which he lost control while driving down a road known for frequent accidents. His car struck the center median and traveled across lanes, rolling over an unspecified number of times before ending up down an embankment on its side. The vehicle was extensively damaged and Woods required extrication from the vehicle with an axe and the jaws of life. First responders reported that Woods was alert at the scene, but that he had suffered significant injuries to his right lower extremity. Woods was transported to a level 1 trauma center, Harbor UCLA Medical Center. He was assessed by the orthopedic trauma specialist who treated Woods for comminuted open fractures of the upper and lower right tibia and fibula, and fractures of the foot and ankle. Damage to the soft tissue surrounding the bones was extensive enough to require fasciotomies to relieve pressure from swelling within the muscle compartments. After surgery, Woods was reported as being awake, responsive, and recovering in his hospital room. Clearly, this was a very serious accident and the injuries suffered quite grave. A first responder commented in an interview that based on the damage sustained by the vehicle, Woods was lucky to be alive. It is significant that Woods was only 2 months out from his 5th back surgery, a microdiscectomy. Prior to this accident, Woods had stated in an interview that he was unsure whether he would be able to compete in the Masters golf tournament later this year.
7 weeks from today, final round of the Masters. You gonna be there?
Gotta hope so. I got to get there first.
Hopefully, Woods will recover from his injuries without any significant complications. However, there are several factors that may influence the arc of Woods' recovery over the ensuing months. Here are 5 important considerations for Tiger Woods' recovery moving forward. Number 1. The open fractures. An open fracture is an injury where the bone has perforated the soft tissue envelope and become exposed to the environment outside of the body. In layman's terms, the bone has come out through the skin.
What?
This is a serious injury that automatically raises the severity level of the injury sustained. With this injury, there is a need to avoid infection and all of the other associated complications, including delayed union, non-union, cellulitis of the surrounding skin, osteomyelitis of the involved bone, persistent infection of the surgical implant, and possibly even amputation of the involved extremity in some cases. There may also be associated soft tissue loss over the affected bone itself, in this case the tibia, so a flap may be required for soft tissue coverage. This is another operation beyond his initial one. With an open fracture, it is common for more than one operation to be required to address the injury sustained. With some particularly bad injuries, several irrigations and debridements, INDs, are required before the wound is suitably clean and all necrotic or dead non-viable tissue has been removed. Sometimes this is required because the soft tissue injury evolves over time. Should the degree of contamination that is associated with the fractures be extensive, a prolonged course of intravenous antibiotic therapy may be required. If this is necessary, a PICC line, a special type of long-lasting intravenous line, will need to be implanted for its delivery. Number 2, fasciotomy. This operative technique implies that there was a very high energy imparted at the fracture site or that there was a significant crush mechanism involved at the site of injury. A fasciotomy is a procedure where an incision is made in a soft tissue compartment in order to allow pressure and or swelling to be dissipated or relieved from that soft tissue compartment. With this procedure, there is a need to watch for delayed necrosis or death of tissue of the involved extremity, in this case the lower leg, including muscle tissue and nerves. There is also a need to watch out for associated complications including infection and an inability to close the fasciotomy incision if the swelling does not dissipate within a reasonable time frame. This might necessitate a skin graft to cover the exposed muscle tissue. This is again another operation, and it may be a separate operation from the proposed soft tissue flap that was discussed previously. Number 3, the segmental fracture. Here we're talking about his fractures of the proximal tibia and the tibial shaft as well. A segmental fracture is a fracture of multiple parts of the same bone. This is an unstable fracture that also implies a high energy mechanism of injury. While it can be readily fixed with intramedullary rod fixation, it is more difficult to do this because there is a segment of fracture that is essentially free floating. This means that it is not attached to the body above or below by anything other than soft tissue. This segment of bone is harder to control during the operation, making the operation more technically challenging and increasing the chance of rotatory mismatch.
What'd you say?
This type of injury makes it more difficult to judge the normal rotation of the bone when it is being fixated. With the segmental nature of the fracture, the periosteum of the bone, the protective saran wrap-like covering, is disrupted in more than one location. This will result in delayed healing time of the fractures involved. Therefore, we can expect a healing time that is considerably longer than it would be if there were an isolated fracture. Number 4, other associated injuries. The high energy nature of the injury mechanism and the injuries suffered are associated with other injuries in the tissues of the lower extremity. There are muscles and nerves within the lower extremity that can be injured directly in the collision or indirectly as a result of what occurs after the collision, up to, including, and after surgery. Muscle tissue can be lost due to necrosis or tissue death as a result of the forces imparted during the collision. Tissue can also be lost by surgical debridement as surgeons work to clean and remove contaminated or damaged tissue, or tissue that has become devitalized or unresponsive to electrical stimulus. This can result in defects in the muscle tissue with associated weakness in certain muscle groups. In severe cases, muscle transfer surgeries may be required if there are significant amounts of muscle tissue that are lost. Nerve tissue can also be lost or injured by either direct damage during the accident or subsequent indirect damage by compartment compression, infection, or debridement during surgery. Loss of nerve tissue can result in loss of sensory or motor function in the parts of the lower extremity innervated by the involved nerve. In the lower extremity, the nerve that is of particular concern is the common peroneal nerve. This nerve travels around the fibular head and into the lateral compartment. It innervates the muscles that control eversion of the foot, dorsiflexion of the foot, extension of the toes, and some intrinsic muscles of the foot as well. It also provides sensation either directly or indirectly to the skin on the lateral aspect of the leg and the dorsum or the top of the foot. Number 5, intra-articular fracture of the ankle. This is an injury that involves the articular surface of the ankle. This means that the fracture line extends into the joint surface and possibly causes the joint surface to become incongruent or uneven. After fracture, surgeons can tolerate up to 2 millimeters of displacement at the joint surface when stabilizing the fractures operatively. This degree of displacement or less will minimize the chances of postoperative arthritis of the ankle. If the joint surface is damaged in such a way that the displacement cannot be reduced, or that after reduction there is a persistent defect or gap in the articular surface, then post-traumatic arthritis may be a possibility. This may result in stiffness in the ankle and difficulty walking on uneven surfaces in the future. As many are, I'm wishing the best for Tiger's recovery and I'm looking forward to seeing him compete on the links again in the future, hopefully sooner rather than later. How long do you think his recovery will take? Be sure to let me know in the comment section down below. Thanks for watching. I will see you for rounds next week. And as always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.